Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
Today's episode is the second in our heel pain series, and I sit down with my partner, Dr. Sequioa Ducasse, to discuss the implementation of diagnostic ultrasound in the management of complex heel pain, as well as further discussion of the staging and grading mechanism to determine the severity of plantar fasciopathy. I think you'll find this episode very interesting and with many ideas that can be clinically implemented in your practice in the management of complex heel pain. So without any further ado, Dr. Sequioa Ducasse. All right, welcome everybody for today's episode. This would be the second episode in our heel pain series. I'm here again with my very esteemed and loved partner, Dr. Sequioa Ducasse, and thanks for coming up and helping me out with this one.
Thank you for having me, Dr. Barrett. It's my pleasure.
So we talked about the staging and grading of plantar fascia in the previous episode on heel pain, and I wanted to go into that just a little bit more. And so maybe our audience can go to the show notes because there's going to be a lot of basically visual things. We'll embed the PowerPoint in the show notes for them, but we'll just generally talk about staging and grading. And, so what do we have in the room? Is it an elephant or is it a mouse?
Yeah. We talked about how not all patients fit into the same algorithm, and how do you determine what tools you need to fight what you're looking at, right?
Right.
And so how did this whole staging and grading come about? What was the thought process behind deciding how to stage and grade the fascia?
Well, I think the first thing was the implementation of ultrasound. And then once we started seeing a number of these patients clinically, it brought to my attention that the plantar fascia would look a certain way in patients that were like recent onset, more mild, more intermittent. And so started making a lot of clinical observations and trying to correlate it. And then if you look at the literature, most of the peer-reviewed literature on sonography of the plantar fascia deals with just a measurement really just anterior to where the calcaneus would end, or the end of the exostosis. And we saw in some patients tremendous variations of thickness and hypoechoic signal intensities in areas right underneath their calcaneus, as well as in the anterior and then very anterior portions of their plantar fascia. So right away, I figured that we needed to divide this up a little bit so that we could distinguish really what we're talking about. So the first step was to what I call get in the zone. And I'll post this on the show notes. But basically, we named 3 zones. Zone C was for infracalcaneal. Zone B would be where the fascia, quote, originates from the bone. And we know that it doesn't really originate there, that it's a confluence underneath the calcaneus most of the time and conjoined with the Achilles insertion, and then very anterior. So we named those Zone C, Zone B, Zone A. And they played some important role in how we managed these folks clinically. But then we did a study at Midwestern University where we looked at 98 normal feet, and they had no symptoms ever in their life of plantar fascia pain. And we looked at their different zones. So the Zone C underneath the calcaneus, the Zone B at the traditional area where you would read in the most of the medical literature refers to, and then anteriorly. And so we were able to take those normatives from 98 feet and determine kind of an average. And we looked at Zone A, usually was below 3.5 millimeters. Zone B, which again is the point where we talk about in the most of the medical literature, is less than 4 millimeters, and then underneath the calcaneus, less than 2 millimeters. Now, what we found was very interesting, because if they had a very thickened Zone C, which means their plantar fascia directly infracalcaneal, if it was greater than 2, that really played a very significant role. And those were the most recalcitrant cases. Those were the ones where we had harder times getting people better. And then so we would combine the measurement of the plantar fascia with the signal intensity. And if you look at our, I guess, table here, that you can see on the y-axis, it's severity of the hypoechoic signal, meaning is it a normal echogenic pattern or is it hypoechoic? And then on the x-axis would be the thickness of the plantar fascia. And you can see down in the right-hand corner, you would have maybe a zone 4C or type 4C, which would be that it's a very hypoechoic signal intensity combined with a very thick plantar fascia. And these are all at the Zone B measurement area. And those are the folks that, quite frankly, that's the elephant in the room. Mm-hmm. You know, you're taking a mouse gun to them, you're not going to do anything but just, aggravate them.
You're right.
And they're not going to get better with orthotics, and they're not going to get better with, 1 or 2 steroid injections. And we figured that out very quickly. Now, people that were earlier or more in the less thick, less hypoechoic stages, they would respond very well to orthotic therapy and stretching and an occasional injection, but rarely would we deal with steroid. Just don't really like steroids at all. So that's kind of where we try to get an idea of placing these patients. And then, how long have they had it? If they've had it less than 6 months, we would call that a stage 1. If they had it less than, 2 years, stage 2. If they had it greater than 2 years, we'd call it a stage 3. So you're able to really kind of get an idea of what's going on with this particular patient. And maybe that should change the way we think about treating these patients rather than just the general algorithm that we talked about in the first episode.
Yeah. So, of course, we ultrasound the patients and we're looking at all the different anatomical landmarks that denote Zone A, B, and C. Is there a zone that matters most? I know that's a difficult question or a loaded question to ask, but is there a measurement that sort of trumps the other?
Yeah, so that's a great question. And if we take out the possibility of like an acute rupture or tear of the plantar fascia,
right,
undoubtedly it would be Zone C.
Mm-hmm.
Now, what's real interesting...
And that's that infracalcaneal measurement.
That's right under the calcaneus. Right. Now, when you look at these with in a short axis on the ultrasound, you very often, instead of seeing a nice crescent moon shape as you come anteriorly, but still we're looking at the bottom of the calcaneus, you'll see like this little bump. I'm not talking about the inferior calcaneal exostosis. What I'm talking about is an irregularity in that osteology.
Right.
And so what's happening there, my theory hypothesis is that as you strike the ground in a supinated position, the calcaneus then rolls down into a more pronated position. And if there's an irregularity on this calcaneus, then the soft tissues will react accordingly, and they will become, hypertrophic and dystrophic. And I think that's what leads to a lot of the degeneration. And those folks are harder to treat. And so, yeah, that would trump like a zone B measurement or a zone, a zone B or a zone A measurement. Right. So, but I like this, and we've got it taped on our ultrasound machine just to kind of remind us, because I think it gives us a lot of insight into, what's the initial approach, initial thought process of how I want to go about treating this plantar fascia.
Yeah. And then we talked about not just the thickness of the measurement, but the quality of the tissue.
Right.
Right. So when you evaluate the plantar fascia under the ultrasound, when we're making these measurements, are we medial band, central band? How are we orienting the ultrasound, and what is the quality of the tissue that we're looking for to say that this is normal or not?
Yeah. So this is really where a little bit of the subjective nature comes in, because what is super hypoechoic to you may not be super hypoechoic to me. But the beauty about it, unless they present bilaterally, is that you have a control.
You have the control
for
of
them.
Right.
So you can go over to their asymptomatic foot and have the control for that person.
And
so
you should be able to evaluate the surrounding tissue too. The fat has different echogenicity than the fascia should, right?
Well, yeah, and then we're going to have some experts on fat pad later on in this episode, which I'm very anxious to hear what they have to say. But one of the things I want to see, what's the significance of their fat pad, if any, right? And that's the beauty about ultrasound, because dynamically we can press on it, see how much there is subdermally to the calcaneus in a compressed state versus non-compressed state. We have some ideas of what normatives should be, but I really don't have any literature that I can source or cite right now. But you can get an idea. If they have skin on the bottom of their calcaneus, they probably have had a ton of steroid injections.
Right.
Right. Now we're dealing with a really problem.
Right.
And that's one thing I think, people will argue, well, which is better, an ultrasound or an MRI? And I think the ultrasound is the gold standard for heel pain. And the reason is that it's real time, it's dynamic, much less expensive than an MRI. And so you can follow these patients along, especially if you're doing regenerative technology, and see these changes serially. And you couldn't do that unless they were just like a billionaire with repeated MRI.
Right.
So, but yeah, and I'll put this picture in the show notes. But here you can see in this photo that we've got basically a long axis, or this would be a sagittal view of the medial band of the plantar fascia, and you can see directly under the calcaneus. It's extremely thick, and I think we've got it measured at 5.3 millimeters, where it should be less than 2. And so there is some hypoechoic signal intensity in that. And then if you look anteriorly, there's also some significant degeneration in the zone B. Now, what you have to be careful about with ultrasound is the anisotropic effect of, just the placement of your transducer. So sometimes you can trick yourself up. You have to be, make sure that the fascia has a curvature to it. So you have to kind of look at it in different, movements with the transducer head. So that's kind of how we want to kind of stage it and grade it. Now, if we go back to the staging, I can tell you that we've found if they're in a pretty severe, like a 3A, B, or C, those folks do extremely well with BPC 157 peptide. They also were the folks that did well back in the early 2000s with PRP. And then, 2010, along came amniotic, or like stem cell, as we like to refer to it, or don't like to refer to it, but amniotic fluid nonetheless. And those folks did extremely well. But if they were farther over on the spectrum, we would still give them a choice, because I would rather not take them to surgery than to, take them to surgery if I can get them better with a regenerative technique. So that's where we started doing, ultrasound guided, basically partial plantar fasciectomies. We would, minimally invasively 1-2 millimeter incision, go in, scrape the
debride that fascia.
Yeah, debride it.
Right.
And then your biologic, or then your peptide
or whatever.
It's gonna
right.
it's gonna have a higher success rate. So and then the interesting thing we found was that, PRP worked very well, but it was more painful than the amniotic fluid. And then the ultrasound changes with PRP, usually we would see ultrasound changes 6 to 8 weeks post-treatment. Then when we adopted amniotic infiltrations, we would start seeing around between 4 and 6 weeks, we'd see substantive changes on the sonography. And then with peptides, it was like, wow, 3 weeks, we could see almost sometimes like total regeneration. So the BPC 157 seems to be pretty spectacular on that. And if they don't get better from that, then we would, at 6 weeks, I would probably give them another round of BPC 157. And if they didn't get better at that point, then we would probably say that they would need to have some type of intervention, like an endoscopic plantar fasciotomy. But preface all of that with the fact that we've taken everything else out from a diagnosis standpoint.
Right.
There's no mixed etiology. This is just we're talking about solely plantar fascia.
Yeah. I mean, we spoke about the heel pain questionnaire previously, right? At what point does that come into play? Of course, that's sort of an HPI, stage, or in the stage of the HPI. How do you integrate that questionnaire with this grading system? What is the interplay there?
Oh, that's really great. Great question. So if they score on the questionnaire very high, then you got to look for nerve pathology. All right. And one of the keys is they've already had orthotics and it made them worse, right? And then you look at their plantar fascia. Then when you do your imaging, you can go back to that questionnaire and kind of put the two together.
Put the pieces, right?
Exactly. It's kind of like looking at a crime scene and talking to a witness.
Right.
And that witness may have not seen the shit that's gone on at the crime scene, or may have seen it perfectly well. Right. And then you can marry them together. But I think the value of the questionnaire is, okay, we're going to look at this plantar fascia. And if it's a significant portion of their mixed etiology heel pain syndrome, or multiple etiology heel pain syndrome, then we're going to want to know, how bad is it? Right. It may be mild, or it may be very severe. And then that's going to factor in, well, when do we look at nerve decompression versus taking care of the plantar fascia? That's a deep discussion. Yeah. So what I'm getting is that the multiple etiology questionnaire doesn't necessarily tell you that this is 50% plantar fascia, 50% nerve, or this is 20% nerve and 80% plantar fascia. It just lets you know there's something else hanging out here that you ought to pay attention to. Exactly. So the only thing the staging and grading does is it gives us an assessment of the plantar fascia.
Mm-hmm.
That's it.
Right.
But it doesn't tell us if this patient has a medial calcaneal nerve entrapment or lateral plantar nerve entrapment. Some people like to use the term Baxter's nerve.
What is that? Is that a real thing?
Well, it's one of the things.
Lay it out on the table.
Oh, it's one of the things that irritates the hell out of me, really, because, Reg Holt talked about that nerve in, I think, 29 or 39, and the poor Dutch guy, he gets ripped off.
Right.
And then I think another guy, Przyslipski, maybe. I'll have to look at the literature. It's been a while since, and he reported this, and then suddenly Baxter comes along and they name it after him. And
like, Christopher Columbus is the whole thing, right?
Yeah. So anyhow, supposedly Baxter's nerve is the first branch of the lateral plantar nerve, and we know from literally thousands of cadaveric dissections that it's the first branch of the lateral plantar nerve is highly variable. And so it's a nonsensical nomenclature. Mm-hmm. And at least it points people in the direction of thinking about nerve versus plantar fascia. I
mean, I don't mind when I hear it for exactly that reason, right? Because to me, it sort of lets me know that we're thinking of something else. It's not just the plantar fascia pathology there, but in the rest of it, I'm sort of like, well, what does that even mean?
Right. So I think then that gets to the question, well, what do you treat first?
Right. It's a chicken or an egg situation.
Right.
And so I think that's a really good segue. How do you determine what is the major pain generator? You see a patient that has multiple etiology heel pain, mixed etiology heel pain.
Right.
You ultrasound their fascia and there's clearly an issue there, right? You do an examination and you figure out what the other thing is contributing. Right. How do you ferret out where to start or what's the major pain generator?
Well, I think that goes back to the value of grading it. Because if you have a patient that comes in, first of all, you're going to history of present illness, first step out of bed, it hurts a little bit, but not much. It's intermittent. And then you marry that up with your imaging that shows a pretty mild degree of degeneration within the plantar fascia. You're probably going to subordinate that to the nerve as the primary pain generator. But if you find a severely degenerative plantar fascia, then that, I think, would subordinate the nerve. And I can tell you from my clinical experience, this was back in the day when, I was accused of raping the plantar fascia. And
How dare you?
Yeah. I love Lowell Scott Weil. I think he's done more for our profession than probably any other single individual. And he did more for me by writing that article because it actually created a lot of controversy about endoscopic plantar fasciotomy. And, it brought it out to the table so it could be discussed. So, and I became friends with him after our big debate in Chicago. But, if the case was back then, we were cutting plantar fascia, and we would see medial calcaneal nerve entrapments, but they didn't seem to be on our radar as much. Mm-hmm. And more often than not, after we cut their medial band, that
improved. Right.
And I had a hard time understanding that, but I thought, well, maybe the vectors changed a little bit in the fascia of the abductor hallucis as it goes posteriorly on the medial aspect of the heel, and maybe it was enough to take the pressure off or change the vector or something. But we did in fact see many medial calcaneal nerves that improved. So if I have a very severe plantar fascia, based on the not only the sonogram, but also what the patient's telling me, then I'm probably going to treat the plantar fascia first, but I'm going to educate the patient that, they have coexisting nerve entrapment. This may get worse, actually, after the heel is treated for myriad reasons, but most of the time that doesn't happen. But, occasionally, I've seen people where they had a subclinical tarsal tunnel. Their fascia was just really very, very bad. And we would do a medial 1/3 fasciotomy, and their heel pain would go completely away. But then they started developing medial medial plantar nerve or lateral plantar nerve pathology, and that's just simply we changed the vector in those tunnels. And then the nice thing about being old and around for a long enough time is that other people publish things that then kind of tell you, oh, that's why.
That's why
it happened, right?
Why was I seeing this?
Yeah. Like a great example of that is in some of the earliest EPF cases, when we were doing total fasciotomies, we would see an occasional stress fracture of the second metatarsal. I was like, wow, wait a second. That's totally related. But in fact, it really is very related because of what's happening with the plantar fascia and the anterior forefoot in offloading, being able to pull that phalanx down to offload that met head a little bit. And then, literature was published in around, I think, 1999, 2000. Sharkey was one of the authors. We can link these in the show notes. But they looked at cadaveric specimens where they would cut different segments of the fascia, and they would see different, load changes. And so it's nice. I mean, if you're around for a long enough period of time, it's like, well, somebody publishes something that, unlike the Leon Muehlman article that we talked about, that just kind of destroying your
it dispels
paradigm.
That whole theory, right?
Yeah, but a lot of times you'll see things that are looked at, and it's like, oh, now there's an explanation for this, and that's really kind of what you have to think about when you see these things. You make these clinical observations, and sometimes you don't have the explanation for it yet, but it may come in the future as it did here. So that was a very long-winded answer to your question, but I think the other question is, what if they have it bilaterally?
Yeah.
Do you do them both at the same time? I don't, because we found about, believe it or not, 50% of the time you take care of the worst first, the other one gets better.
Yeah. Plus, you got to give them a good leg to stand on.
Exactly. That's exact. No pun intended, right? Or pun definitely intended. Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at SavantCellars.com. That is CEVANT Cellars.com. Spelunk15. That's how I would, go about it. And I think, there's less post-operative morbidity associated with a plantar fasciotomy if it's done correctly than with, any type of tarsal tunnel decompression. And that's why I would, defer to, if the plantar fascia is really, really thick and really hypoechoic, and I can't get it better with regenerative technology, then I would address it surgically before I would address the nerve issues. We should get the nerve fellow to work on correlating maybe the MEP scoring with some of the sonography findings. Might be very interesting. That was a great question that you posed. I mean, I do that all the time, but really have never thought about it. It was just something that, take for granted.
And how many of the time, or how often do you think And when you address the plantar fascia, even if they have multiple etiology, heel pain syndrome, how often when you address the plantar fascia, and you may not be able to give me a number, but how often does like the tarsal tunnel go away, or, the isolated medial calc issue, or the Baxter's neuritis, right? How often does that improve following, handling that major pain generator?
Yeah, so you're right. I don't have a number for you, but it's pretty significant.
Mm-hmm.
And, empirically, like we see in nerve surgery, we may identify 10 pain generators, but we never treat 10. We'll treat maybe 1, 2, and 3.
Right.
And then what happens after that?
Yeah, everything generally calms down.
Right. The body, you give the body a chance. It's pretty miraculous. And so, same thing here.
We talk about the screaming kid in the classroom sometimes, right?
Right.
Like you walk into this first grade classroom and this one kid screaming and going crazy, and you just think that the whole class is bad, but it's not. It's that one kid. If you can calm that kid down, the class becomes a lot more manageable. And I think when you talk about heel pain, especially plantar fasciopathy that's compounded with something else, that's sort of an overlying theme.
Right. Now, here's another interesting thing. So let's say they come in with very recalcitrant heel pain.
Mm-hmm.
And you look at their fascia and it's pristine.
Okay.
And we have seen these cases.
We have.
Right.
Uh-huh.
Okay. And it's a damn good fascia. And it's not
textbook.
What?
It's textbook.
It is textbook.
Right.
And so it's not a plantar fasciopathy that's their pain generator. So then you start looking around and all of a sudden medial calcaneal nerve. Mm-hmm. And you give them a little 0.2 cc of lidocaine and all of a sudden all their heel pain's gone.
Mm-hmm.
And they're magic, right?
That's right.
And then what you do is you do a neurosensory test on them and all of a sudden they have sensory deficit in peroneal, tibial, both legs. The footprint of diabetic peripheral neuropathy.
Right.
Now they've never been diagnosed.
Never been diagnosed, right?
No,
right.
They've
no history of this at all.
And then, so the next thing you send them for some tests, and they're diabetic.
Mm-hmm.
So the first marker of diabetes, many times, is a nerve issue. And I was talking to Dr. Nickerson on, not only on one of the other episodes, but also, just as colleagues and friends. And it's more often than not, if you ask a patient, when were they diagnosed with type 2 diabetes, they'll say, maybe a year after I had some tingling in my toes.
And the feet,
that type of thing.
Yeah.
So diabetes can be a very early nerve entrapment, specifically medial calcaneal nerve, can be a very early marker of diabetes. And then when you work these patients up and they've come into you for heel pain, and you've made the diagnosis that they're a type 2 diabetic, and you send them off to their internist or their endocrinologist, they're like scratching their head going, wow, I just went to that dude just because my heel hurt.
Yeah, how did he figure that out?
Yeah.
Right.
Well, it's because you chase we're a bunch of symptom treaters,
mm-hmm.
right? So, person comes in, sore heel, I'm going to press on that thing with my thumb, and I tell you, my thumb's not that damn good. It's not as good as the transducer on the ultrasound, but, you press on it with the thumb, yet you've diagnosed it within 30 seconds, you pop them with a steroid and boom, out the door,
mm-hmm.
right? So we just treat the symptom. We don't figure out, well, why do they have it, right? So taking the time to look at, well, is there equinus there? Is there other nerve entrapments? Sometimes they're so subtle that they don't present, with the patient, they're insidious. The patient doesn't know they have a sensory deficit until they're tested in these other nerves. So I guess it's just, you're going down to try to find the genesis of the problem rather than just treating the symptom. And I think that's one of the things that we've really had to look at from some of our complex neuropathy patients. So the same thing applies to anything, whether it's heel pain or some other condition. Now, were they looking at, in your residency, a lot of ultrasound on the plantar fascia, or was it more just a the thumb and steroid method?
No, I've only ever seen an ultrasound in residency in a textbook. I didn't even know what the things looked like, honestly. No, we never did any ultrasound imaging. Even throughout school, we were just exposed to it, in the radiology class, and it was sort of, this is an alternate means of, imaging, soft tissue masses and whatever.
Right.
We never talked about utilizing it for, identifying pathology within the heel. We use it every day. I mean, I feel like it's an extension of myself in the clinic now, right? It's almost something once you start to utilize it and you're able to see, you can't not see without it.
Right.
I think even now, I rely on ultrasound more than X-ray when it comes to heel pain.
Right.
For the reasons that you described, the fact that it's very dynamic, it's real time. When I press on it here, I'll see exactly what that does to, if they have some intracalcaneal or intrafat pad swelling or anything like that. You see the fluid displace, right? Like you can actually see, the changes within the tissue density as you're doing your examination. And so now I think it's fantastic. I wouldn't be able to treat anyone without it, but in residency, absolutely not.
Right.
No way.
What do you think the big barrier to entry is for the average podiatrist as far as integration of ultrasound into their offices? Is it cost or is it learning curve?
You want the politically correct answer?
No, I want the unfiltered, no bullshit
So
answer.
To be honest with you, I think, in podiatry, we're afraid of our own shadow, number one, and we have the self-imposed box.
Okay.
Right? And so, we can treat the warts or we can treat the plantar fascia, but if it goes outside of the convention that everyone else is doing, we don't want to stray too far outside of that because you're afraid that, you're going to get in trouble or something like that. And so I think as a profession, we're really afraid of our own shadow. And a lot of people are not willing to step outside of that box and innovate. Right. I think that's the first barrier to entry. The other part of it is maybe cost. But when we talk about the cost of an ultrasound, there are so many different options that are way less expensive than an X-ray. Getting an X-ray installed in the office, right? And you can get so much more information. So I think that it's there's just a lack of knowledge, right? I mean, we have these little pocket ultrasounds that you can use, and it give you a really rudimentary image, of course, but you can at least see what you're treating. Right. You can use it for needle guidance, needle placement. We talked about how good is your thumb at determining are you in the fascia or not with whatever that solution is that you're injecting. It's not so great. I mean, you can do this, I don't know, for 20, 30 years, but you're going to miss every now and then, right? And to be able to see where you're actually injecting makes 100% sense, especially if you have the capability to do that. We're not in the dark ages anymore, right? We should be able to evolve with medicine. But I honestly think that we're lazy.
No.
I think we're lazy. It's easy to have a heel pain patient come in and you say, okay, my protocol is 2 steroid shots, 6 weeks of therapy, night splint, and then surgery. Right. Practice management.
Okay. But, one of the barriers that I've seen is that it's not the financial aspect because people realize that you actually get reimbursed quite well for using your ultrasound, both for injection, infiltration guidance, as well as just a true, study of the tissue that you're looking at. But I think it's a training issue that what is it that I'm really looking at on that screen? And it's very difficult to learn some of these things other than just by jumping in and you're in the middle of the river and you got to swim.
Yeah.
And so I think there's a hesitation of some practitioners when they first start with ultrasounds. Am I really seeing what you're telling me that I'm seeing? And I mean, we just started our new nerve fellow, and I've noticed this with her just in about 3 weeks, she's becoming so much more comfortable of identifying nerves.
Mm-hmm.
But it took that clinical experience to get, with somebody kind of like flying in the right seat with her, and I think that's one of the big impediments, or the abyss between clinical understanding and clinical implementation.
Yeah.
With ultrasound.
No, I agree with you. I mean, it's with most things, as with most things, it's experiential, right?
Right.
You look at enough plantar fascia, you get like this Rolodex of what it's supposed to look like.
Right.
Right. When you're looking at the central band versus the medial band, you understand positioning, you understand, just what that tissue is supposed to look like at what portion of it. Right. You know where the zone C is before you even measure it. You can tell there's pathology there.
Right.
But if you don't do it, then you wouldn't know what normal would look like.
Right.
If you're not exposed to it, you wouldn't really know. And some people, I guess, you sort of get into the thick of it with practice, and it's difficult to learn new things once you're already there.
Right.
And if what you're doing is making you money, it's difficult to, unless that person's really searching.
Right.
Right. It's really difficult to change a person's paradigm.
Yeah. And, I've always looked at monetization as a secondary factor to patient outcome. And when I was very early in my residency director said, don't ever worry about money, worry about the patient, the money will come.
Mm-hmm.
And so there's nothing that I hate more than when somebody comes to one of our training courses and the first thing they ask is, what's the CPT code for this?
How do I get paid on this?
Yeah, it's like, you don't get it, dude. That should be the last question you ask.
Yeah.
And anyhow.
Yeah. I mean, even utilizing the ultrasound in the office, right?
Right.
It doesn't cost you anything to put the ultrasound on the patient.
No.
I mean,
maybe a little time.
Yeah. And just, a couple pennies worth of gel, really. Right. But the value that you gain from seeing the actual tissue that you're treating and improving that patient's quality of life, even if you're not billing for it, you're a better clinician because you've seen what you're doing.
Right. No, if they said, we're not paying for ultrasound anymore tomorrow, which insurance companies could do because they do that with other stuff.
Yeah, or they could do it because it was raining last Tuesday.
It wouldn't change my utilization of ultrasound whatsoever, because I just think it's also a really good metric for the patient, because the patients can look at that and they can look at their other heel and they know. Oh,
yeah,
wow.
They can see the difference with their untrained eye.
Right.
They can.
They're
tell
not a radiologist,
difference.
but they damn sure can see that's the big, thick, fat one over there.
There's a big black hole where there should be nice, organized tissue.
Exactly. And then when you do regenerative therapy and you can show them how that's regrown, very powerful. Just like all the photos that we take intraoperatively of nerve decompression, because a lot of these patients feel like they're crazy. They've been labeled as, not, psychotic and not having any true pathology. And then when you show them that hourglass deformity where their nerve was pinched, all of a sudden that validates them. I believe that actually helps them from a postoperative standpoint immensely. Yeah. It's interesting. So I guess to wrap it up, I would say, if you consider yourself an expert in heel pain and you're not using an ultrasound in your practice, you're either, I'm going to get very.
I'll say it.
I'm going to get very punished for this.
Go ahead.
You're either disingenuous or you're deluded and you just are ignorant, So I've just probably pissed off a lot of people, but the fact of the matter is, you're not an expert if you're not implementing this type of technology in your diagnosis and in your treatment methods. Just my opinion. Now, at the end of the podcast, there's a disclaimer that says this may not be my opinion. So, but,
No, but I think the point of it is that we could be doing a lot better job at treating a few of these patients, a little more than a few of these patients. And if we have the training and if there are resources out there that can help us to do that, we should utilize them.
Right.
If you don't know, you don't know.
Right.
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 But if you do know and you don't do, that's a different thing.
Right. And the thing too is that the eyes can't see what the mind doesn't know. And once these guys come through these courses and they know what to look for, suddenly they're all there.
Yeah.
They were never there before.
That's deep.
But they are all there. It's very deep. We just went spelunking. And,
we're real deep now in the cave here. Yeah.
But it's true, right? I mean,
it is.
Some of the stuff that I do routinely, had I not been in a situation where I saw it with my own eyes, it was like, whoa, you can read all the articles in the world and then you see it work one time in a patient's like, that's more important than all those articles.
Yeah. I mean, even myself in residency, all heel pain was plantar fasciitis until proven otherwise. And now my eyes see differently.
Right. Totally. So, all right. Well, we'll wrap it up and look forward to our next episode. And we'll be bringing some very cool stuff on heel pain. So, again, go to the show notes if you want to see some of the illustrations that we were looking at. It's podofinquiry.com. And we hope to have you on our next episode. Thank you. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find us a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.